So when I entered medical school, within the first year, we had anatomy and physiology. And one of the most challenging anatomical organ was brain. And at the same time, the neurophysiology was the most interesting as well. So it was a great combination of challenging and interesting thing, and I gravitate towards such kind of fields anyhow. So when I came to the US, where I came right after medical school to do my residency, we typically, to start residency in US, need to build some research profile, have some research experience, which we, at least back then in India, we didn't used to have those opportunities. So when the chance came, I naturally picked up like anything to do with neurology or neuroscience. So I did research in neuroimaging, I did basic neuroscience research, and kept liking and loving and enjoying it. And when the time came to apply to residency, my path was clear that I want to go into neurology. So I started my residency in Rutgers University in Newark, New Jersey, and I think I can say it for many or most neurology resident, when they come to neurology residency, most of them are really impressed by stroke, the glamour of stroke, because it's very acute, and you go in like a hero in the ER, and you give the TPA, and you see the change right in front of your eyes and feel like you're saving a life, right? So I was quite interested in doing stroke fellowship, and beyond stroke, I also wanted to do interventional neurology, where they go in and through endovascular route try to take the clot out. That was quite glamorous back then when I was training. So I did a lot of rotations in those subspecialty as well, but almost frankly like movies, the way it happens, because I still remember the mirror in my bathroom in one fine morning at 5 a.m. getting ready and like standing there and thinking that if I do stroke, this is gonna be my life. And I love challenges, but I was like, maybe when I'm 60, I would not enjoy this being called in the middle of the night. Maybe it would not be for me. So thankfully that I was going into something just for maybe glamour at that time, and it gave me a moment to pause and reflect. And I'm like, no, not stroke. And then the decision was very easy, because when kind of that the shades of or that rose tinted glass of glamour kind of went away, then I pursued my natural interest, which was the reason I came to neurology, was to understand brain, like how brain functions and how brain works. And the only field, in my humble opinion, that gets to the meat of that question is epilepsy, because we do a lot of neurophysiology, electrophysiology, how seizure semiology emerges, and how the seizure travels, and how it's gonna make the head turn to one side and the eyes going to other side, and all these subtleties that we try to understand, and try to understand the brain from neuroimaging, functional neuroimaging, electrophysiologically, stimulating electrophysiologically, SEEG. This is the only way to understand brain. So then my path was very clear. I want to do epilepsy. So I applied very late because I was thinking of stroke, but thankfully I got opportunity to do fellowship at Cleveland Clinic, where I stayed for 2 years, and they were kind enough to offer me a position as a staff physician. So now I have been there almost 10 years. This July will be my completion of 10 years, going into my 11th year of being an epileptologist, adult epileptologist. That's all. So as I mentioned, I practice in the US at Cleveland Clinic in Ohio, and one of my area of clinical and scientific research interest is acute symptomatic seizures. So these are seizures that happen after acute brain injury, like traumatic brain injury, stroke, and things of that nature. And in the last 2.5 decades, a lot of work coming primarily from the US has shown that after the clinical seizure, if you are able to monitor these patients with EEG, many of them may still continue to have electrographic seizures. So one of the opportunities or benefits of working in the US has been the very wide availability and ready availability of being able to monitor a patient off hours, in the evening, night, on the weekend. So whenever an emergency arises, we're able to provide this EEG monitoring and able to monitor the patient. However, that of course, like with any opportunity and any new paradigm of medicine that we explore, those opportunities also bring challenges. And the challenges have been, when we see many things on the EEG which are abnormal, what is the right way to treat, how aggressively to treat, how our management and use of anti-seizure medications are impacting the outcomes, are they making any difference or not. So those are the challenges because of the almost like a novelty of the field and something that's kind of developing in front of our eyes and we're developing it. The challenges come from trying to understand how to manage such things and how can we improve the outcomes, because every step we take is to improve a patient's life who comes to hospital. So whatever we are doing, are these things really making a difference or not? That is a challenge for the future. Yeah. Sure. So as I discussed during the talk today, when we are faced with patients who have acute symptomatic seizure, our first reaction should not be to start every patient on medication. We need to understand what is the underlying cause. So if it's something very transient like a systemic injury like hypoglycemia, hyponatremia, those kind of, maybe we can be more conservative and not be too aggressive with anti-seizure medication. And if a person has on the other end of the spectrum clinical acute symptomatic seizure, which is maybe even status epilepticus and is because of acute brain injury like traumatic brain injury involving cortex, intraparenchymal hemorrhage, and which are acute brain injuries of more severe form, maybe starting them on medication, but ensuring that those patients are not left on medication for very, very long time or several months and years, because these are typically people who are older, have had some other acute brain insult for which they are already on medication. So we want to make sure that if they are temporarily requiring anti-seizure medication, that we have a good follow-up and make sure that we are able to safely de-prescribe and stop these medication. So that's a message definitely I would like to share with my colleagues, is to have a good dedicated outpatient follow-up so that the patients are not left on these medication for months and years and unnecessarily. And the second point is that as our research is showing and our colleagues at some other centers, is compared to the prognostic benefit of predicting seizure reoccurrence after discharge that we were seeing initially from the acute EEG that we were doing, it seemed like the EEG done after hospital discharge outpatient can be even much more informative in terms of predicting the risk of seizure reoccurrence. So again, this is a challenge for the future. When is the best time to do EEG that can inform the seizure reoccurrence risk? But our data lately has shown in a couple of papers that outpatient EEG findings have a lot of prognostic benefit in seizure reoccurrence.